Still.
Good afternoon, Tygerberg team. Let's see, I see Erica Marie and Sylvester here. Hi. And we always wait until there's about 40 people before we start, and we're sort of there, 40. So that's a good moment to start engaging and saying hello to everybody that's here on this. Oh, suddenly there's a bit of sun in Cape Town, in this early winter's day in Cape Town. Yeah, welcome to everybody. And we really, really look forward to hear about cells with hairy projections. It's the type of thing I learned in my 3rd year of medicine and my 4th year. And it seems, you know, they were quite big. And I always wondered what it was. I wonder if it's still in the curriculum. Cells with hairy projections. Anyway, let's continue and just get the housekeeping out of the way for today. So for those who don't know that already, recordings may be found under resources on the website. And the CPD points will automatically be submitted to the HPCSA, and if there are problems, please let Melanie on our side know at UCT. And please take part in the conversation. Please do put comments in, and the whole idea behind being together on a Monday afternoon is to get to know each other and to be free to let one's voice be heard and ask questions. Thanks, Fatin. So the people who put together the program with your input and listening to what you guys would like to speak to, here we are. Let us know what you would want. So today on the agenda is the team of Tygerberg, and led by Dr. Professor Z. Chapandu. So the first, it's very interesting and very lovely. I think anybody who looks through a microscope absolutely adores this condition. And then those who treat, or these conditions, let me not jump the gun, and those who treat them are also often with a smile on their face. So for me, hairy cells make me smile. So I'm handing over to Z. Thank you, Tygerberg, for bringing us a topic that I think will make us happy, smile, learn fascinating things, and hopefully help our patients. Welcome.
Thank you very much, Estelle, for the introduction and the housekeeping. Yeah, I'm smiling as well. So yeah, thanks for choosing a time that brings smiles to people's faces. We have two very ambitious presenters. I say ambitious because I think they're going to be a bit pushed for time, going by their own reports. But all I can say is to both Erica and Sly, please cut out as much as you can so we stick to time. Dr. Sylvester Chabunya is a supernumerary registrar from Malawi, and he's been with us for about 2 years. He's already gone through his part 1. Now he's doing a med, and his topic is the hematological profile of hairy cell leukemia and related neoplasms. Today he's going to take us through the process of telling apart cells with hairy projections. And as we all know, as we'll find out, there is a good number of them. And the important thing is to be able to cleverly and correctly identify and categorize them appropriately, as this has got a big impact on the treatment and the patient outcomes. Over to you, Sly.
Hi, good afternoon. Can you see my screen?
Yes, sir.
All right. All right, so good afternoon, everyone. As stated, I'll be taking you through this presentation discussing villous cytoplasmic projection lymphocytes. Just a brief overview of what we'll discuss through this presentation. Just looking at the splenic B-cell lymphomas and leukemia. And basically what we note is that from the new revised WHO HIM5, these are categorized under mature B-cell neoplasms, specifically looking at the splenic B-cell lymphomas and leukemias. We'll touch a bit on the cytoskeletal organization of lymphocytes, as well as what leads to the cytoplasmic projections, how to differentiate these villous cells, and also looking at how we'll diagnose the villous malignancies.
Sorry, Sylvester, we're not seeing your presentation view.
Are you seeing my?
I'm seeing it before it goes in just your general PowerPoint.
Okay, let me just try sharing it again.
No, just slide, just get us onto the presentation mode, and the slides are not advancing. So just sort that out quickly.
Okay.
Thanks.
If you click this little cup thing like a wine glass at the bottom next to the 79% line, at the bottom right-hand corner, well, not the corner, just in from the corner. Don't you have that?
Yeah, is that?
There, perfect. I hope it should work unless the computer is stopping it.
Okay, is that all right, or still showing?
No, you have, yeah, maybe that perhaps there's somebody with more slideshow. If you click on the top next to animation slideshow, perhaps that works. There's a slideshow next to animation on the right hand side. I don't know if that's, I've never had this problem. If I press on that cup, it usually works.
I've pressed on the same button and it's just coming up on.
So the button is not listening to you.
Yeah, is it projecting now? Sorry for that.
Oh, I don't know why.
Sylvester, maybe just, Sylvester, can you see the presentation mode on your screen?
Yeah, I can see the presentation mode on my screen.
Maybe you're sharing the wrong screen then. Just stop and reshare and make sure you share the presenter mode screen.
Try it again. Is it trying? Yeah, try it now. No, not yet. That is a problem. Is it because I'm using the browser?
Why is this standard? Maybe we can
Perfect.
That looks great. But now we've got your notes. I think you should, yeah. Oh, that's better.
Kabunya, we can't hear you. Are you speaking or is it just me?
It looks great, Sylvester. Oh, no, now you're back.
I think it was just muted there. Yeah. So, sorry, are you able to hear me?
Yes, sir.
All right. So looking at the new revised WHO HIM 5, what is important to note here is that for these splenic B-cell lymphomas, what has been omitted in the new classification is your B-cell pro-lymphocytic leukemia, which was noted that most of these were either progression of your chronic lymphocytic leukemia or blastoid phase of your mantle cell lymphoma. This has been in contention since the introduction in the classification in WHO 2001. As well as looking at your hairy cell leukemia variant has been removed as an entity and replaced by your splenic B-cell lymphoma leukemia with prominent nucleoli. But for all the other entities, such as your hairy cell leukemia, your splenic marginal zone, and splenic diffuse red pulp remain the same. So for these splenic malignancies, diagnosis can be made on peripheral blood, bone marrow aspirate, as well as trophine samples, depending on the assessments we carry out on these specimens. The large extent of overlapping clinical and morphological, as well as immunophenotypical features when you try to distinguish these four entities. And of note is that the presence of the BRAF V600E somatic mutation has established a known diagnosis of hairy cell leukemia once it's present. And as Prof. Correctly stated, that distinguishing these entities apart is quite important depending on their different clinical prognosis as well as treatment. While typically a watchful waiting and splenectomy is always an option for all these conditions, we can treat our hairy cell leukemias with rituximab and purine analogs. The splenic B-cell lymphoma with prominent nucleoli, we can apply the same regimen, but it's been known to have a much poor outcome. While your diffuse red pulp can be treated with rituximab with an addition of chemotherapy, and your marginal zone will be treated with your rituximab and cyclophosphamide-based chemotherapy regimens, and this has been known to have a best survival of the four conditions. Briefly, just looking at the cytoskeleton of leukocytes, many of these are protein subunits, which form a lot of physiological properties. So the cytoskeleton is a structure that allows the cells to interact within its own environment as well as other cells. This can be done by recognizing antigens as well as functioning for the immune system for processes such as exservation. And this has been noted with the components of your microfilaments, microtubules, as well as your intermediate filaments. And what's been noted to be increased in your hairy cell projections has been mainly your intermediate filaments, looking at vimentin, as well as there's usually a disruption with your RHO family of GTPases within the cytoskeleton, leading to this projections which are featured around the cytoplasm of the cell. So how can you tell when the cytoplasmic projections that we're seeing are true? It's always important to question whether the cells that we're seeing are in case of an artifact, which can be present due to the preparation of the slide. And this should always be excluded out by looking at the direction in which these these cytoplasmic projections are going with the gradient of the smear and looking at the cell in the cell of interest as well. So it's quite important. It's quite important to exclude things that are appearing on the smear due to artifactory changes, such as storage changes as well, which has been noted that hairy projections have been seen due to EDTA-induced storage artifacts. So when do we then say that that these cytoplasmic projections are pathognomonic? So basically, we want the cytoplasmic projections to be circumferential in some of these cases, and polarity is quite important. And noting that some of these cytoplasmic projections can be seen at a single polar area of the cell, or even up to 4 polar areas of the cell, and be observed in different directions, rather than following the same gradient of where the cell, the smear was prepared. How can we tell when there's the difference between these hair cell conditions? So again, we can try to distinguish these conditions based on demographics, but looking at sex, we do note that there is a slight male predominance when looking at all 4 of these entities. Although it is slightly higher with hair cell leukemia, this is very non-specific in identifying the disease of interest. As well, looking at the age, median age for most of these diseases is greater than the age of 60. So it's really not ideal to diagnose or identify these diseases depending on the sex of the patient or the age of the patient. And due to the rarity of most of these conditions, the epidemiology doesn't really uniform them due to how rare we find these cases, as you can see projected from the WHO statistics. And then we can come down and then look, okay, clinical factors present that can help us distinguish whether this is a hairy cell leukemia, lymphoma with a prominent nucleoli, red pop, or splenic marginal zone. Splenomegaly will be present throughout all these 4 entities, but then looking at your B symptoms, they're quite rare when you're describing your hairy cell leukemia, as well as your splenic B cell with prominent nucleoli, but can be seen in about 1/3 and 1/4 of cases when discussing your red pop and splenic marginal zone. But as well, this will not really differentiate the diseases depending on these symptoms, as well as the presence of an enlarged spleen. This then starts being elucidated when we're looking at our laboratory parameters, mainly our full blood count features. Hairy cell leukemia has been known to be present usually with a pancytopenia, more notably with a monocytopenia present, and lymphocytosis is often rare. While when we look at our prominent nucleoli, pancytopenia can be there, but lymphocytosis is usually more common within this entity. And for your red pop, you rarely have presence of your pancytopenia, and lymphocytosis can be there. And splenic marginal zone, either one can be present. But what we need to take away from this is that your lymphocytosis in terms of hairy cell leukemia is quite rare to be present, and your monocytopenia should really drive you into thinking about hairy cell leukemia when you're starting off with these parameters. So how can we distinguish these conditions based on the peripheral blood smear? So we've looked at the smear and we've assessed that the cytoplasmic projections that we're seeing are actually true projections and not artifactual projections. So the hairy cell has been described to be about 2 times the size of a normal lymphocyte, with abundant cytoplasm and circumferential distribution of cytoplasmic villi. And the cytoplasm stains a pale blue, which has sometimes been described as a tissue paper texture, with this nucleus that takes up a majority of the space of the cell. And sometimes you can have nuclear irregularities, which what has been described most commonly is the kidney shape nucleus in terms of hairy cell leukemia. And what is of note is that these cytoplasmic projections will only be seen on peripheral smear, while touch preparations of either a splenic or a bone marrow biopsy, these projections will not be present. So looking at our lymphoma with prominent nucleoli, the cytoplasm is moderate to abundant, and the cell is usually medium to large in size. It tends basophilic to pale cytoplasm, and the nucleus is usually oval to round in size. And what is evident is this prominent nucleoli, which is usually singular and can be seen through these cells. The distribution of the cytoplasm are usually unequal and may be seen just on one area or not that prominent at all. Well, when we're looking at our red pulp cells, what is of note is that the cytoplasm stains pale. These are usually small to medium in size. The nuclear shape is usually heterogeneous. You can have these oval shapes to the round shapes. But what we note is that the distribution of the projections will either be in a single pole or up to even 4 poles of the cellular circumference. And usually these projections are a bit longer than what you see in the other 3 entities. While for your splenic marginal zone lymphoma, these are also small to medium in size. Heterogeneity of the nucleus can also be commented on, where some will have a clefted nucleus, but the nucleolus is often small and sometimes not visible. The cytoplasms are shorter compared to the other 3 entities, and the cytoplasm is usually moderate in amount. So when looking at splenic features of these 4 entities, the pattern of infiltration when discussing hairy cell leukemia is diffuse infiltration of the red pulp with associated atrophy of the white pulp and blood lakes. And the way these blood lakes are defined is that this can be seen on a macroscopic examination of the spleen. This is either due to post-splenectomy. Splenic biopsies are often not done due to the complication of hemorrhage. So what we see is that the cells will infiltrate in a diffuse pattern. Looking at your prominent nucleoli lymphoma cells, they also do have a diffuse infiltration of the red pulp. Also with associated atrophy of your white pulp. But what we note is that there is prominent intrasinusoidal involvement of the red pulp when discussing these prominent nucleoli cells. For our splenic diffuse red pulp, there is also a diffuse pattern of infiltration in our red pulp, mainly looking at the cords and sinuses. These macroscopic blood lakes are also found, and this is attributed to disruption of the blood vessels within the red pulp, leading to your pseudosinuses, which can be seen in this image here. And finally, looking at the pattern for our splenic marginal zone, this is predominantly macronodular and less frequently involving. They can be involvement of both the white as well as the red pulp of the spleen. So moving on to the pattern of infiltration when we're discussing the bone marrow. Hairy cell leukemia, the cellularity is usually variable, so it can be from increased to hypoplastic, but the pattern is very distinct in the sense that there's usually a patchy to interstitial with this fried egg appearance noted, where you have prominent cellular borders and the nucleus being situated in the middle of the cytoplasm, giving that fried egg appearance. And this is mainly due to the secretion of fibronectin from these cells. And what's been noted is that fibrosis will always be marked in terms of a hairy cell, and aspirate is usually a dry tap when attempted. And this, in comparison to the other entities, you have your normal cellularity seen in your prominent nucleoli lymphoma with normal, which can be normal to increased. The pattern is often interstitial to intrasinusoidal and may sometimes be nodular, but fibrosis will always be mild when dealing with this entity. Well, for your splenic diffuse red pulp, cellularity is quite variable with sufficient residual hematopoiesis seen. The pattern of infiltration is noted to be intrasinusoidal and is almost always present, and interstitial and nodular is quite rare. Fibrosis is not often noted within the bone marrow, so an aspirate would be producible. Looking at your splenic marginal zone, cellularity of the involvement is also variable, but we know that there's a nodular pattern, and interstitial and focal intrasinusoidal infiltrates will be seen with mild fibrosis. So when we do the bone marrow biopsy, once the resulting aspirate has been a dry tap, we need to actually then think about whether this is due to marked fibrosis and leading us to think whether this is a hairy cell leukemia compared to the other ones. But then if you're dealing with these three other entities, it's quite difficult to ascertain which entity it is depending on the fibrosis present in the bone marrow. So looking at these diseases in order to distinguish them based on the immunophenotype, they'll all be positive for CD20, but what we do notice that most of them will be CD5 and CD10 negative. As well, we can this will be further be distinguished when looking at the expression of your cyclin D1 and cyclin D3, where hairy cell leukemia is likely to express your cyclin D1 most positively. And for your cyclin D3 is more common with your splenic diffuse red pulp and your other two entities not expressing these on the surface. As well as looking at your annexin 1, this is more significant when we're looking at hairy cell leukemia. So you can see that adding up this presence and comparing them to your other three entities, it will give you more of a stronger bias to go towards hairy cell leukemia. So we'll discuss the hairy cell markers on the next slide. But what I would just also want you to note was that previously diagnosis was made with cytochemical staining with your tartar-resistant acid phosphatase. But since the 1st of December last year, NHLS has discontinued this test, and WHO no longer puts it in one of the diagnostic tests for hairy cell leukemia. So for our immunophenotypic score, so the score is basically based on the four class of differentiation markers: is CD11C, CD25, CD103, and CD123. And it's been noted that usually these are given 1 point each for their presence, and hairy cell leukemia usually scores a score of 3 to 4 in about 98% of cases. So this is being used to differentiate hairy cell leukemia to these other hairy cell-like conditions. And what we note on the splenic B-cell lymphoma with prominent nucleoli is that these cells will express your CD11 and CD103 and will be negative for CD25 and CD123. For your splenic diffuse red pulp, what is of note is that your CD25 will be negative, but in some cases you can have present for your CD103, CD123, and CD11C. And for the splenic marginal zone lymphoma, your CD103 will be negative, but you may have one of these markers being positive with your immunophenotypic score. And this does help to have a favorable bias towards your hairy cell leukemia if the score is greater than 3. Further now, looking at the expression of many your CD 180 and CD 200. So the median fluorescence ratio is helpful in distinguishing splenic diffuse with the other entities, with a ratio of 0.5 or less favoring the disease. And this is looking at how your CD 180 is strong in about 100% of your cases, and your CD 200 is dim in about 40% of the cases, while in comparison to your other entities, the ratio can never be lower than your 0.5. So having discussed the morphology as well as the immunophenotyping, can we distinguish these conditions based on our mutational landscape? As discussed previously, looking at hairy cell leukemia, the presence of your mutation in your BRAF V600 will lead to a diagnosis of hairy cell leukemia. And this is basically something that has been, we started testing this in 2011, and it has been a change in the way we diagnose our hairy cell leukemia. As I stated, that for TRAP testing has been discontinued. And also looking at your other recurrent genetic mutations, of note is that for cytogenetics, looking at your 7q deletion, it doesn't really differentiate one entity from the other. So basically, doing the molecular testing will actually lead us into other mutations, which will hopefully add more value to what we found out from our peripheral assessment, our bone marrow biopsy assessment, to be able to elucidate which entity we're dealing with. Looking at the splenic B cells with prominent nucleoli, your MAP2K1 mutations are seen to be more common compared to your other entities. So this would add more value with your morphological findings as well as your immunophenotype score, if you're still debating whether this is the entity that you're looking at. While for your splenic marginal zone, your Kruppel-like factor 2 mutations have been seen to be a bit higher when compared to the other entities. And for your splenic diffuse red pulp, your BCL6 co-repressor mutations and deletions are present in about 24% of cases, and this can rarely be seen on negative in your other entities. So briefly, just looking at the whole picture in summary, in terms of our distinction, we really start seeing the distinction when we look at our laboratory parameters when it comes to your full blood count, where your pancytopenia will be there, but your monocytopenia will really push you towards thinking about hairy cell leukemia compared to your other entities. In terms of your immunophenotype, as we discussed, this will be CD5, CD10 negative, and your immunophenotypic score will lead you to whether you highly favor hairy cell leukemia compared to your other entities. For cytomorphology, something that is also of note is that your hairy cell leukemia cell, as well as that of the prominent nucleoli, are a bit larger compared to your splenic diffuse lymphoma cells, as well as your splenic marginal zone lymphoma cells. So looking at the size of these cells and the distribution of the cytoplasmic projections can lead you towards which entity you should favor compared to their appearance. As discussed, fibrosis is often seen with our hairy cell leukemia. So whether the bone marrow be aspirable, if you're able to get an aspirate, you can think that it's less likely to be hairy cell due to the high degree of fibrosis which has been seen in this disease. And the pattern should really lead us to have a better way of distinguishing this. So if you see that fried egg appearance, high fibrosis, you're more likely to think towards the lines of your hairy cell leukemia. But if you're seeing these intrasinusoidal or nodular, it will lead you to think about these other entities. And lastly, looking at your presence of your BRAF V600 mutation being present exclusively for your hairy cell leukemia will much better help you distinguish it from the other three entities. Thank you.
Thanks, Sylvester. That was quite a lot you covered in there. And I would urge colleagues who are going for exams and all of that to request some of these slides from Sylvester so that you can have some of the tables as aid memoirs. And there's a way of remembering things. Now, without further ado, let's move over to, we'll take questions at the end, if you don't mind, and let's have Erica speak. Erica is one of our own, trained here, pass cum laude, you know, the usual. I like also to add that she got the quota medal. She doesn't want me to mention that, but it's a fact. Erica is an asset from our side because she's very much interested in all the key aspects of the job, from the teaching. She mentors our registrars and supervises MEDs and all those beautiful things. Takes registrars within a, you know, within a class and takes them through exams. And I found that to be quite a big help for the department and for the registrars themselves. Erica is now going to put it all together by looking at a few cases. Erica, take it away.
Thank you, Prof, for bragging on my behalf. I appreciate your kind words. So let's just get this sharing. Okay, what are you seeing now? Are you seeing my presenter view? Okay, that's good. You are
Yes,
seeing
ma'am.
it. Excellent. Okay, so we're going to go through some case studies so that we can put everything that Sylvester has taught us into practice. The first little disclaimer is that of all the tests that Sylvester had mentioned, we do not have access to all of them. So when we are working up these cases at Tygerberg or within the NHLS, we don't have access to TRAP, like you mentioned, and we also don't have access to annexin 1, which is expressed in hairy cell leukemia. We don't have CD180 on flow cytometry, so we aren't able to calculate that CD200, CD180 ratio that helps us distinguish the splenic diffuse red pulp from the other conditions. And we do have BRAF mutation immunohistochemistry available within the NHLS adverts. However, we found at Tygerberg that when we send our trephine samples there, that we often have negative results, even though the BRAF mutation is positive on molecular studies. So we don't think it is very reliable on our trephine samples. But it is important that we do have access to the mutation testing for the BRAF V600E for hairy cell leukemia. However, we don't have any other molecular studies to help us distinguish the other conditions. So we're going to do 4 cases, and we're going to use this table that was presented by Sylvester to help us decide which of the malignancies is best fitting. So case 1, we have a 50-year-old male. He had disseminated TB and completed treatment, but then had a persistent pancytopenia. Vitamin B12 and folate levels were normal. He had lymphadenopathy and hepatosplenomegaly. And he had a bone marrow a year ago that was just mildly hypercellular. So this was a repeat bone marrow for pancytopenia. You can see the white cell count of 1.99, HB of 7.8, and a severe thrombocytopenia. And our differential count is showing a monocytopenia with a normal lymphocyte count. So on the peripheral blood, we see these atypical lymphocytes. We've got a normal lymphocyte here for comparison. You can see that these lymphocytes are large in size. They have abundant pale cytoplasm, and we can see the hairy projections. The cytoplasm is so pale that it's actually quite difficult to project these on the screen, but I hope that I'm pointing out those hairy projections to you. And the nucleus is either oval or has these beautiful kidney or indented nuclear outlines, and the nucleoli are not prominent. The bone marrow aspirate for this patient was a dry tap. So flow cytometry was performed on the peripheral blood, and the cells of interest were identified as CD45 bright with low complexity. They were CD19 and 20 positive. If we look at the CD5 over here, we can see that there's a green population. Those are the T cells, not our population of interest, but our population of interest is this light blue population over here, which are CD5 negative. And they are also CD10 negative. If we look at our hairy cell markers at the bottom, we can see that our cells are CD11C positive, positive for 103, positive for 25 and 123. And they are also positive for layer 1, which is another marker of hairy cell leukemia. The bone marrow aspirate, the bone marrow trephine, the architecture wasn't overtly disturbed. In fact, if you look at these 5 times magnification, it almost looks as if the architecture is quite well preserved, until we look a little bit closer and we can see that all of these cells are monomorphic. So there is no disruption of the normal fat spaces, indicating an interstitial infiltrate. These cells are medium to large in cells and quite widely spaced apart. And if I've projected here on 100 times so that you could see the absolutely beautiful fried egg appearance of these cells, we can see the cytoplasmic outlines and negative space in between. So we stain these with CD20, which is a B cell marker, and CD3, which is a T cell marker, and all of the cells of the infiltrate were positive for CD20, with only a few T cells in between. And BRAF V600E mutation was detected by PCR. So we can quite convincingly say that this is a perfect case of hairy cell leukemia, where it followed all of the rules very nicely. Does someone have a question? No. Okay. So case number 2, this was a 54-year-old female with peripheral blood morphology that had lymphocytes with hairy projections. Unfortunately, we didn't have any clinical information at the time of the bone marrow, but a bone marrow aspirate interferon was performed for diagnosis of this condition. The white cell count was raised owing to a lymphocytosis. Interestingly, there was a monocytopenia, and we had a mild anemia and thrombocytopenia. If we look at the morphology of these cells, here I have a normal lymphocytes again for comparison. So these cells are medium in size, and they have cytoplasm with hairy projections, which are quite polar. I'm going to point them out to you on this side and on this side. The nucleus, the nuclei have clumped chromatin. And there are occasional that have these small nucleoli, but others that don't have any nucleoli. The bone marrow aspirate was aspiratable with beautiful particles, and the particles were markedly hypercellular. And in the trails, we can see an increase of lymphocytes. I'm going to point it out to you over here. They made up 48% of the myelogram. Some of them had villus projections. Flow cytometry was performed. So these cells were CD20 positive, CD10 negative. They were CD19 positive over here, and CD5 is negative. Again, these CD5 positive cells are the T cells, which we know can express CD5, but they are CD19 negative T cells. They are clonal, they only express in lambda. And then for the hairy cell markers, they're expressing CD11C, but are negative for 103. They're not expressing CD25 or CD123. If we look at the trephine and the pattern of infiltration, we will see that there is a disturbance of architecture. There are these nodular infiltrates that are disturbing the architecture. And if I zoom in there, we can see that these are monomorphic lymphoid cells, which we stained for with CD20 and CD3. So not only are there these nodular infiltrates, but we can also see interstitially there's an increase in the B cells. And we know that normally the T cells are more than the B cells. So this would be reversed to the normal. And even though there's focally increased T cells, we can always see that the CD20 is more than the CD3 at all positions. So for this case, we did have a monocytopenia, and it is stated that rarely splenic marginal zone lymphoma does have a monocytopenia. For our patient, they were expressing CD11C, but CD103 was negative, and CD25 is only seen in a third of cases. The morphology was pretty much in keeping with this cell morphology, medium-sized cell, no prominent nucleoli, quite clumped chromatin, and polar villi. Bone marrow was aspiratable, and we had nodular and interstitial involvement of the bone marrow. So we had very plain, straightforward cases of hairy cell leukemia and splenic marginal zone lymphoma, but case 3 and case 4 are a little bit more difficult. So we will go through them. This patient was a 68-year-old female with massive splenomegaly and a pan or bicytopenia. The peripheral blood, again, we identified the lymphocytes with hairy cell projections, and a bone marrow was done as for diagnosis. The white cell count is mildly reduced with a neutropenia and again a monocytopenia. We have a HB of 9.4 and a platelet count which is reduced for age, but it's greater than 150, but it is within the lower limit of the platelet count. The peripheral blood morphology, we can see that these cells are medium in size with moderate amounts of cytoplasm, and they've got hairy projections, not particularly large hairy projections, they're quite small. And the other thing that we can notice here is that there is a prominent nucleolus in most of these cells. Bone marrow was aspiratable with hypercellular particles. And again, in the trails, we can see that there are increased number of lymphocytes, and it was 25% of the myelogram. And then some of these had hairy projections with prominent nucleoli. The flow cytometry for this patient was performed showing a population that was CD20 positive, negative for CD10, CD19 positive, negative for CD5. They were lambda clonal, and then they were negative for CD11C. We just have 10.65% of these cells on the side, negative for 103, negative for 25, and negative for 123. And the pattern of infiltration in the bone marrow was a nodular to interstitial pattern. We can see that there is disturbance of the architecture by these nodular infiltrates. I've zoomed in here on a nodule for us. And then we can see that these are composed of medium-sized lymphocytes, so monomorphic infiltrate. These nodules are staining positive for CD20, We can also see the CD20 highlighting the interstitial distribution of these lymphocytes as well. And CD20 again is more than CD3. So for our patient, we did have a monocytopenia. So this is typically seen in hairy cell leukemia, but the rest was not in keeping with hairy cell leukemia. Like I mentioned, it does say that rarely splenic marginal zone can have monocytopenia. For the immunophenotype, it was negative for all the hairy cell markers. So it doesn't really help us to distinguish in which category we are. The site morphology was somewhere between a splenic B-cell lymphoma with prominent nucleoli and a splenic marginal zone lymphoma, because we did have these nucleoli, but we didn't have a lot of cytoplasm, and they were quite, the hairy projections were quite small. Bone marrow was aspiratable, so that doesn't really help us distinguish between the conditions. And the pattern of infiltration was nodular and interstitial. So splenic diffuse red pulp has intrasinusoidal infiltrates, which are always the rule. And we did not see intrasinusoidal infiltrates, so we have excluded that entity somewhat. But distinguishing based on pattern infiltration of splenic B-cell lymphoma with prominent nucleoli and splenic marginal zone is quite difficult. And then we didn't perform the BRAFI 600E for this patient. So in the end, this was signed out as possibly splenic marginal zone or lymphoma with prominent nucleoli. When the clinicians prompted us to give our best diagnosis, the pathologist had decided that it favored actually hairy cell variant was made on the previous WHO classification, but this would have now fallen into splenic B-cell lymphoma with prominent nucleoli. So the last case that we're going to look at is a 73-year-old female with splenomegaly. She had lymphocytosis of 13.91, and those lymphocytes had hairy projections, so diagnostic bone marrow was performed. Other than the leukocytosis, we do have a anemia of 8.5 and a mild thrombocytopenia. The morphology of the cells, they have cytoplasmic projections, but they don't have abundant cytoplasm. The projections are quite irregularly seen, and there are occasional small nucleoli that are present, but the connection is otherwise quite clumped. The bone marrow was aspiratable, and again we can see increased lymphocytes that were 39% of the myelogram, and several of them did have hairy projections. Flow cytometry of this patient showed the B cells were CD20 positive and 10 negative, CD19 positive, CD5 negative, and they were kappa clonal. They expressed CD11C, but were negative for CD123, 103, CD25, and CD123. The pattern of infiltration in the bone marrow trephine, we see again a nodular pattern. We've zoomed in over here to see this lymphoid aggregate. But what we also saw in this patient is intrasinusoidal infiltration. So I'm going to highlight the outside of the sinusoid. We can see the sinusoid, and then we can see the lymphocytes within that sinusoid. So we also have intrasinusoidal infiltration for this patient. CD20 is on the side highlighting that nodular infiltration pattern quite beautifully, and within those nodules, CD20 is more than CD3. There's also an interstitial increase in lymphocytes, in B lymphocytes. So for this patient, when we originally looked at the patient, we thought this might be hairy cell leukemia, and so we did send PCR for BRAFI 600E, but the mutation was not detected. So let's have a look at what we found for this patient. There wasn't a monocytopenia, great, so we're in this category. We had expression of 11C on our cells. So does this help us? So they can all express CD11C, but what was noted for the lymphoma with prominent nucleoli is that they usually express CD103. So perhaps this one is slightly less likely. For the morphology on peripheral blood, these cells have hairy projections that are irregularly spaced, but they are small in size, so they do have prominent nucleoli. So again, it's sitting kind of between this lymphoma with prominent nuclei and splenic marginal zone and splenic red pulp. The bone marrow was aspiratable, which doesn't help us distinguish between them. And then the pattern of infiltration in the bone marrow, we had intrasinusoidal infiltrates. So this brings splenic diffuse red pulp lymphoma back into the differential. However, it is noted that nodular infiltrates are rare, and the nodular infiltrates that we saw on this tref line were quite prominent. So again, we steered away from that to say that it's probably going to be either splenic B-cell lymphoma with prominent nucleoli or splenic marginal zone lymphoma, and the mutation was not detected. So in summary, bone marrow is often the only tissue available for diagnosis of hairy cell leukemia and hairy cell leukemia-like conditions. The only other tissue that is normally available is the spleen, and this is usually performed as part of treatment when you have a therapeutic splenectomy, that tissue is available because these patients do not get lymphadenopathy, so lymph nodes we aren't able to diagnose these on lymph nodes. So your hematopathologists are very important for diagnosis of these conditions. Hairy cell leukemia is more recognizable than the other conditions, and therefore often more reliably diagnosed because of the pattern of infiltration in the marrow, but also aided by the availability of the BRAF V600E molecular test. The rest of the three conditions have overlapping morphology and immunophenotype and infiltration pattern. So often we have to provide a differential diagnosis with a favored diagnosis. Molecular testing would be very helpful for us to give a better diagnosis for these three conditions. And one of the things that we are doing at our center is we have a MSc student who is going to have a look at other mutations within our population of hairy cell leukemia and hairy cell-like conditions, so that we can see if this aids our ability to diagnose these mostly rare conditions. And he's going to be looking at MAP2K1 mutations, which is mainly seen in the prominent nucleoli condition, NOTCH2 mutations, which is mainly seen in splenic marginal zone, and cyclin D3 mutations, which is seen slightly more commonly in splenic diffuse red pulp, but is helpful across the board to help us distinguish from hairy cell leukemia. Great, thank you. Thank you for traveling through the different conditions with me and seeing the difficulties that can be faced when trying to distinguish these conditions from each other. We know it's very important because it aids your treatment decisions. It's always good to work together as a team so that we get enough clinical information. Perhaps B symptoms might be a clue, perhaps any other lymphadenopathy might be a clue to help us distinguish between these conditions. Thank you.
Thank you very much, Erica. Very comprehensive, and I believe your cases, in my opinion, illustrate just how difficult it is to tease these apart. If you're lucky, one, is quite obvious, it reveals itself. But my experience is that we often have to resort to tables and books. Now, there's nothing wrong with that. And our junior colleagues remember that as a pathologist, speaking to the pathologist, you always need to have textbooks and sources. Don't try and be a hero and memorize these things. And even if you have memorized them, do take a look and check, especially for difficult cases. Now, I'm just looking out for questions here. And I haven't seen one. If you have a question, please just unmute and speak. I will not be able to see the raised hands. So please, just jump in and say what you want to say. We have a lot of time, so please make use of it. But if there are no questions, so be it. Questions, please. Estelle, back to you. It looks like we don't have questions here.
That's a problem.
It is a problem.
I think you gave it, you both of you, Sylvester and Erica, you gave us a textbook of you know, good options. And I absolutely agree with what Z is saying, that even though it's in your head, it's a great idea to go check again. We've got such wonderful resources, and this is now one. So I think spread the word that if we ever want to smile about hairy cell leukemia or its variants, then this is the place to come. So I don't know, is there anything, Sylvester and Erica, from you that you would like to add? Or
Yeah,
is
sure. I'll just add one
Yeah.
more thing that I found quite useful. It's sometimes quite difficult to see intrasinusoidal infiltrates, and it might be the only thing that is able to help you when you're distinguishing those conditions. So we found that highlighting the sinusoids using immunohistochemistry, either CD34 or factor VIII, is useful to identify those intrasinusoidal infiltrates. I don't know if that would also be helpful for anybody else.
Thanks, Erica. There is a question here from Lina Tamali. Do you routinely do hairy cell markers even in all cases of CD5, CD10 negative BLPDs?
Thank you, Lina, for your question. It's very, very relevant. And whenever we see CD5, CD10 negative B-cell and proliferative disorders, we do think for a second, do we need to go on to do a hairy cell panel? And it is at the discretion of the pathologist who is signing out that flow cytometry. But it is something that we definitely consider in all of them. And we review the morphology very carefully at that point to decide whether we should go on for hairy cell markers, looking at the morphology and also the clinical presentation.
Thanks. Another question from Abigail Glover from SMU. Morphology was quite tricky. How would you differentiate between pseudosinusoidal and sinusoidal?
Thank you, Abigail. I think I might have alluded to this
Yes, you have,
using
actually.
your immunohistochemistry to help you, because it may be difficult to see that sinusoidal infiltration. So CD34 highlights the endothelium, so does factor VIII. It also highlights the endothelium. I don't know if any other centers use other markers. Those are the markers that we commonly use here to identify our sinusoids. And then looking for that infiltrate within those highlighted sinusoids. Thanks.
Abigail, if you have another question or if you are not satisfied, please just unmute and ask another question. Do you have any more questions off the floor? Oh, well. So back to you then, Estelle. All I do is thank everyone from my side for giving us the opportunity to present to you and for attending. Thanks.
Well, likewise, thank you very much, Team Tigerberg and Lab. And thank you very much, Erica and Sylvester. Oh, there's another question. So my thanks are a bit too quick. Another question for you, Erica. Maybe.
Yeah, sure. So thank you, Sharon. I see that you're asking about the usefulness of CD43 for the diagnosis of marginal zone lymphoma. So it's a little bit out of the scope of the splenic B-cell lymphomas that we were discussing today. And there may be some other useful indications that we have a marginal zone lymphoma, like CD5, they have lymphadenopathy, which was not seen in these splenic B-cell malignancies. But CD43, in my limited experience, often follows CD5. So in those conditions where we have CD5 positive lymphoproliferative disorders, CD43 is also normally positive, but it is part of our immunophenotype arsenal, and it is useful in the diagnosis of marginal zone lymphoma together with the translocations 1114.
Good. Sharon Officer, if you have another question, please just unmute and ask, or if you need clarification. Oh, I see. Okay, good. That settles that.
I
Any
think
more
we can
questions?
thank you for a quick and a very concise and wonderful topic. I think everybody's relieved to have an early Monday afternoon.
Yes.
Okay,
Yes.
thank you, Estelle.
So thank you, team. Very well done. Thank you. Thank you,
Yeah.
everybody. It was very nice to be with all of you this afternoon. Have a good week.
Thank you.
You too. Thanks, Estelle. Thanks, everyone.
Thanks.